Welcome everyone. My name is Jenny Hornick, and I'm the Digital Marketing Specialist here at JMIR Publications. I'm very excited to welcome you to our first ever webinar with JMIR Perioperative Medicine. In today's session, we'll be hearing from JMIR Perioperative Medicine's Editor-in-Chief, Dr. Nidhi Rohatgi, in conversation with Dr. Praveen Kalra and Dr. Dmitri Nepogodiev. We will begin with that in just a moment, but before we do, I just have a couple of housekeeping items that I want to go over. First off, you will notice that your microphones are muted. We do encourage that you ask the speakers questions as they come up, but you can do so by entering the questions in the Q&A box, which you can find at the bottom of your screen. And there will be a designated time towards the end of the session for the panel to address the questions. Additionally, we are recording this session and it will be available on our YouTube channel sometime later this week. So for anyone who misses the event, you can share the recording with your colleagues. And so without further ado, I would like you all to join me in welcoming Dr. Nidhi Rohatgi. So Dr. Nidhi Rohatgi is a clinical professor of medicine at Stanford University with courtesy appointments in neurosurgery, anesthesiology, perioperative, and pain medicine. She is affiliate faculty at both the Center for Artificial Intelligence in Medicine and Imaging and the Stanford Center for Digital Health. An accomplished author and speaker, Dr. Rohatgi's work focuses on improving perioperative care through interdisciplinary collaboration and innovation. She currently serves as editor-in-chief of JMIR Perioperative Medicine. So with that, I will let you take things off, Dr. Rohatgi.
Thank you so much, Jenny, and welcome everyone. We're really excited to have two remarkable speakers for today's webinar. And I'm excited to introduce first Dr. Praveen Kalra. He's an anesthesiologist and critical care specialist at Stanford University in California, United States. He has been a transformative leader in sustainability, eliminating desflurane from operating rooms, and that is the anesthetic gas with the highest global warming potential. He has decommissioned nitrous oxide pipelines in the operating room. He's working on reducing plastic and biohazardous waste, managing pharmaceutical waste, and integrating reusable supplies into anesthetic practice. And with all of his work, he has shown significant cost savings at his hospital. He's extremely knowledgeable. His passion for work in sustainability is extremely contagious. And not only that, he has created and designed a green curriculum at Stanford for medical education in sustainability. Our second speaker for today is Dr. Dmitri Nepogodiev. He is a faculty in public health at the University of Birmingham in the United Kingdom. He's trained in basic surgical and public health and is a globally recognized researcher in surgical epidemiology. His work continues to directly inform and influence high priority policy areas in public health, global health. He co-led the COVID Surge Collaborative during the pandemic, one of the most popular studies of all times, and it guided surgical care across the world. And if there is one team in the world that has proven their spirit of collaboration, it is Dimitri's team. They hold the Guinness World Record for the most number of authors on a single peer-reviewed academic paper. I think, Dmitri, it was some 15,000 authors or so on that article, so really remarkable job. Dmitri also co-hosts a Greener Surgery Conference in the United Kingdom, and it is a fantastic conference to learn about sustainability. All right, with that, let's get started. I am really excited. In today's webinar, I am hoping to learn how to change management in sustainability at the level of a hospital and how to think beyond the walls of a hospital. Why is this work important? And how does policy or industry partnership influence this work? So with that, Dr. Kalra, I'm going to pose the first question to you. In perioperative or surgical care, I see so many opportunities to reduce carbon emission. In my own practice, I see that there are so many low-value preoperative and postoperative tests. There are patients traveling back and forth for appointments in their cars and other vehicles. And then there is a lot of opportunity in the operating room, which has been your area of focus. So in surgical care, with your expertise, what do you see are the biggest opportunities to reduce carbon emissions? Why should we talk about it? Why should we think about it? And how do we get there?
Thank you, Nidhi, for a great warm introduction and invitation to speak at the webinar. So I will answer this question in two ways. The first of all, I would answer why surgical services create so much of carbon emissions. And the answer is surgical services are extremely resource intensive, primarily because of the use of electricity, 24/7 nature of the hospitals. Also because it generates extensive amount of waste, be it plastic, metallic, biohazardous, and pharmaceutical, as well as also due to the use of anesthetic gases. So to put it in perspective, hospitals are the second most energy intensive buildings as compared to any other commercial buildings. Hospitals use around 2.7 times of electricity per square feet. Now, operating rooms use 6 times more electricity as compared to any other place in the hospital. Hospitals also generate 30 pounds of waste per bed per day. 30% of the waste comes from the operating room. 60% of the biohazardous waste comes from the operating room. And biohazardous waste is extremely expensive to dispose of. It almost costs 10 times more to dispose of biohazardous waste. And the third thing being anesthetic gases. So anesthetic gases are greenhouse gases. So they contribute to global warming. And its impact is directly dependent on few fundamental properties. What is their global warming potential? What is their ozone depletion potential? What is their atmospheric lifetime? What is their potency? Because that determines how much anesthetic molecules are going to be released into the environment. And also at what fresh gas flows we are using these. So to answer your question, what can we do to get to there to make our surgical care more climate smart? The first thing I will say is to deliver anesthesia in a clean, sustainable manner, which basically means removing anesthetic gases with the highest global warming potential. And for example, desflurane, as you mentioned, decommissioning nitrous oxide. Nitrous oxide in many studies have shown less than 10% is used on clinical care and 90% is leaking from inefficient delivery of pipelines or through cryogenic tank systems. The third thing is using low fresh gas flows. The fourth being, we can use total intravenous anesthetics and trying to promote regional anesthesia. So that is from the anesthetic point of view. Now, the second aspect is energy emissions. Energy emissions have to be looked upon demand and the supply side. The supply side is something which as a physician you do not have control, and that is what the hospital or the C-suite will have to address is, can we convert our electricity source from polluting sources like coal and natural gas to renewable sources? That will address the supply side. In terms of the demand side, very basic things like installing LED lights, motion sensors, addressing air exchanges in the OR during non-surgical periods, because air exchanges consume extensive amount of electricity, are some of the ways we can address that. Now, as I said, 60% of the biohazardous waste comes from the OR. So by educating people what goes where really makes a huge impact. Promoting reusables and reprocessables will go a long way in decreasing your single-use devices and, of course, addressing plastic waste. And pharmaceutical waste. Pharmaceuticals are responsible for roughly around 20% of the carbon emissions in scope 3 carbon emissions. And a pharmaceutical is a chemical first, pollutant second, and a therapeutic agent third. That is the way we should look at each pharmaceutical. And unfortunately, there's an extensive amount of pharmaceutical waste in the ORs. And the last but not the least, I will say, we have to educate our colleagues, healthcare practitioners, that sustainability in healthcare matters, and we can bridge the gap by providing education. So these are some of the ways we have to look at delivering climate smart healthcare.
Thank you, Dr. Kalra. I really like the word climate smart. I think it's a good way to think about it. As you were speaking, I was thinking that there are so many opportunities. How do you go about picking the top few? And how do you make a case to your organization that they should invest the time, energy, or personnel to work on this? Because ultimately, even if we recognize the opportunities, this is a very difficult topic area to influence the C-suite to work on this. So how did you make that happen?
So I think the first and foremost thing is to collect the data, because without having the data, you cannot make a case. That would be the first thing. And so we collected the data. Practice Green Health is one of the entities that provide us the data in terms of what are carbon emissions from anesthetic gases, from electricity usage, and so on. So once you have the data, you made a case that if I am able to remove one anesthetic gas, for example, desflurane, how much impact it will cause. So just to give you an example, by removing anesthetic gas desflurane, our carbon emissions from fluorinated anesthetic gases came down by 83%. And by the way, desflurane is twice as expensive as sevoflurane, so we landed up saving financial savings for the hospital. And that's where I use the term green is the new black. By going with greener services, not only we create profitability for the institution, better environment, without even compromising on patient care, just to give you one example. And also, I can go on the list, but every project which we have done, we have looked at it from three fundamental models. It has to be sustainable, it has to be profitable for the institution, and it cannot compromise on the quality of patient care. And that's how you have to make a case.
I love that. Dmitri, at your institution, and you've worked with institutions across the globe, what do you think are the biggest opportunities, and how have you directed your work to get there?
Yeah, these are really good questions. I think the key is that everyone's starting point is different. So there probably isn't a single thing that everyone should be doing, because it very much depends on where you're starting from. And that will be different in different countries. But even within one health system, actually, different hospitals might have different things already in place. So I think the first thing to do is a sort of needs assessment of what interventions have we already implemented around sustainability, and what are the potential gaps that we could address. And then you need to start to prioritize those and think about, well, where are the biggest wins? Thinking about the effort that's involved and the potential impact. So it might be that there are relatively simple things that might not have a huge impact, but because they're simple, they're a good thing to start with. There might also be things that are a bit more complex that would have a big impact that it's worth thinking about. So just sort of having a matrix of those. And I think involving the clinical staff in that process of mapping out what's in place, what are the gaps, is really important, because to make a positive change, you really need to have buy-in from everyone in the team. Otherwise, you can make all sorts of recommendations and requirements, but they won't necessarily happen. And a classic example is something about waste management that you can say to staff, you need to put your recycling in this bin, and you'll find that it just doesn't happen. And so that's key, is having that buy-in from your colleagues. Now, where my team comes in is that we're more involved in the research, and so the areas where we've been focusing, as Praveen has mentioned, anesthetic gases, working with anaesthetists is one area. But also another big area we've been looking at is around energy, because ultimately, no matter how efficient we make healthcare, we will still need to use energy. But the good news is that we can decarbonize our energy supply. And so some of the things we've been looking at is the feasibility of installing, for example, solar energy solutions. And there's a couple of hospitals in England that have built solar farms in order to generate net zero sort of electricity. And also looking at that overseas, in countries like India and Nigeria, where actually energy security is not just about decarbonization, but it's also about having a steady, reliable supply of electricity to perform safe surgery, because otherwise you're experiencing multiple power cuts as a result of unreliable power grid. So that's a bit of a mishmash of things, kind of going from what the approach might be in the theatre for a particular theatre team or in a particular hospital through to, energy solutions that probably need to be done at a higher level.
Thank you so much, Dmitri. So I think you said some very important things. First, the clinician engagement is extremely important, and everyone will have a very different starting point, and we just need to determine at our own health system what are the biggest challenges that we have. Praveen, let me ask you this, that you did a lot of work at your institution. What were your biggest challenges in building awareness about sustainability, creating this culture of sustainability, or procuring funding? How did it go, and what would be your recommendations for others trying to do the same?
I think changing the culture is one of the hardest things to do in any institution. I'll give you an example that I started learning about sustainability several years ago, and I then decided, I can make all these changes in my own operating room, but the impact is going to be negligible. The real value comes if all of us do it in a climate smart, clean, sustainable manner. And I started sharing this information through grand rounds, through educational forums with our department, with our colleagues. And the idea was we are better together rather than one person doing it. And I honestly pursued the mantra of 3 C's: connect, convey, and convince. Connecting with the audience, making a case, almost as a personal case, why climate change matters to all of us. Conveying the message with evidence. I showed the literature, why these anesthetic gases are bad for us, what is their impact on the environment. Helped me in making a case and convincing. And once everybody wants to do the right thing, so once the evidence was in front of them, I think everybody was unanimous. These are easy, low-hanging fruits, especially in anesthetic gases. By removing an anesthetic gas A, you can actually quantify your carbon emissions, how much it goes down. So that really helped. Now, of course, as I said, they also bring some sort of financial savings for the institution. So that made a case even stronger, that not only we are addressing the financial aspect of the profitability of the institution, but also addressing climate change at the same time. So this is how the journey began. And I would say first start with 1 or 2 projects, show the results, people get convinced. Then it took me much lesser time to convince my folks about taking additional projects. And I'll give you another example. The second project which I did was about nitrous oxide. Now at Stanford Healthcare, medical gases are responsible for roughly around 25% of our scope 1 emissions. So medical gases, and among medical gases, 94% of our carbon emissions are coming from nitrous oxide. And 90% of the nitrous oxide is leaking from the system, with less than 10% being used on clinical care. Nitrous oxide is not an expensive anesthetic gas. For the whole institution at Stanford, it cost a little less than $60,000. But its impact was almost like 4,800 metric tons. So when we decommission nitrous oxide, we have recently completed decommissioning nitrous oxide at pretty much all facilities within Stanford Healthcare. We anticipate 94 to 96% reduction in our carbon emissions. So in terms of savings, the number may be low, but in terms of its impact on climate change, the number is very high. And I think the C-suite and the leadership really understand that this is a very vital project for Stanford Healthcare to reach its scope 1 and scope 2 emissions goals of reducing them by 50% by 2030, we have to address nitrous oxide. So that's how these small, these projects carried value in terms of not only financial, but more of them as in carbon emissions point of view. So to answer your question, I think the concept of best patient outcomes has to involve optimizing our resources as well as pollution prevention. And with all these projects, we have made a very good business case that it is good for the environment as well as it is addressing climate change.
So I'm hearing win, win, and win, that we can do good patient care, we can save the environment, and we can save money. So that is excellent news. And from what I'm hearing, I actually did not know that it's like really that work on nitrous oxide could save the carbon emissions by that degree, 90 to 95%. That's huge win. So congratulations on that work.
Thank you.
And Dmitri, you've been involved and you've seen, I looked at the Greener Surgery Conference. There were so many presentations as well around nitrous oxide, and there were multiple institutions who were presenting about how they have achieved this change management and culture of change and sustainability and focus at their institutions. What were your key learnings and what would be your recommendations to other institutions starting to work on this?
Yeah, so I think the situation in the UK has been that there has been some national level policy direction in this area to move away from desflurane and to decommission it. And so some hospitals have been early adopters of that, and they've kind of gone ahead and already achieved that. Other places have probably been a bit slower. And some of the factors that might explain that is the importance of having dedicated leadership. So I think, like Praveen, you need somebody who's going to be a hands-on, passionate leader who moves their department, their hospital forward. So that if you don't have that, then it's going to be challenging, I think. So someone needs to take that on. So I think that's one element. I think having the evidence to back the change you want to achieve can also be important. One of the factors that stops people from changing is the people generally are concerned about change, that, will it have an impact on patient care? Will it have an impact on hospital operations? So building up the evidence base to demonstrate the safety and impact of the change you want to achieve is also important. So I think those are the things: leadership and evidence, and I think working together as a team to just work through what could be the potential challenges and barriers, and how can we overcome those. So bringing the team with you also important.
That's fantastic, Dmitri. So I'm hearing that a dedicated leader in this space is extremely important. I'm a very hands-on person when it comes to any improvement work or any new project. And I think for such kind of a work, it is important to kind of go in the guts of the hospital and see those pipelines yourself, see where the leak is happening, actually see it with your own eyes, and then show it to the people who won't go in the guts of the hospital. Being that hands-on person is extremely important to move this work forward. It's as you both were speaking, I was imagining where I started in my career in medicine, and I started with reusable drapes, reusable gowns, glass syringes that we would boil, procedure kits that were reusable. And then suddenly the world switched to everything disposable because we were trying to reduce infections, or we thought that was the right thing to do. And now we have to go a full circle and do studies to show that, well, reusable was not that bad after all, maybe. So it is an interesting full circle that we have come. And I don't know if you or others in the audience probably share the same journey of going, a full circle and understanding that we started with reusable everything. Dmitri, let me ask you this, that you are a global health researcher. You have this green surgery team, you have this green surgery conference, and you and your team do groundbreaking trials across UK and several low and middle income countries. Your latest trial that I'm really looking forward to is the Dragon trial. So what have been your key learnings and doing research and innovation in this field? What is your advice for the audience, policymakers, researchers, innovators, industry partners, whoever you think needs to hear this? What are our opportunities in research and innovation here?
So I think research is really important because, going back to the previous point, we need evidence to demonstrate that the change we want to make is effective, and that means that it's either safe, doesn't harm patients, or that it actually improves patient outcomes, that it's cost effective, so either neutral or reduces cost, and the carbon effectiveness. Sometimes what we might initially assume would be a cost and a carbon effective intervention might not always work out that way. And so having the evidence, it saves us from spending time implementing things that are actually counterproductive. Conversely, things that people might have some doubt about, might prove to be quite effective. So to give you a concrete example of that, a couple of years ago, we did a trial called Cheetah, which looked at the impact of routinely changing gloves and instruments at the time of abdominal wound closure on wound infections. And this was quite a big trial, about 12,000 patients across 80 hospitals worldwide. And what we found was that routinely changing gloves and instruments would reduce wound infection by 13%, which is a small reduction, relatively speaking, but it's a very simple intervention, so probably worth considering. But one of the reasons why people were perhaps a bit slow to consider changing practice was the perception that routinely changing gloves would increase your glove use, obviously, and that would be bad for the environment. And so one of our PhD fellows, Virginia Leder, has been doing a piece of work where we have created a carbon model, similar to how you might create a cost effectiveness model, using our trial data to show that actually, because you're reducing wound infections, the additional resource usage and carbon footprint of using more gloves is actually more than offset by saving the carbon footprint associated with wound infections. And so it's really quite key to consider that kind of more holistic picture. It's not just about the intervention, but also the impact it might have downstream on the patient outcomes. And generally speaking, if we improve patient outcomes, reduce complications, that will reduce our carbon footprint because we're not having to take people back to theatre and have longer hospital stays and so on. So actually, there's a case for sort of investing carbon almost. So by doing more initially, we might actually reduce the overall carbon footprint later on. So rather than just assuming, oh, well, using more gloves or using more medications, it's bad. You need to have that kind of more research-based view. The second thing that we've probably found is that generally, lots of groups around the world pretty good at doing clinical trials. The quality of clinical trials worldwide has increased over the last 20 years. And surgery, which used to have very few good trials, now has many. And that's all very positive. But one of the challenging areas is once you've done your trial, you've published it in the New England Journal of Medicine. I mean, I never have, but I'm sure colleagues online have. And I think traditionally that's kind of where you kind of said job done and you kind of moved on. And actually, one of the challenges is how do we translate the benefits we see in our research into real world benefits for patients in our hospitals and around the world? And it's that implementation of the research findings into the routine practice, which is sort of the next frontier, and where a lot of the time we're not actually implementing best practice according to the latest evidence. So there are lots of reasons for that. And again, actually, another piece of work that Virginia has done, whilst we've been doing the Dragon trial, is going around interviewing theatre teams, ward teams, managers, procurement teams, to understand, okay, so if we need to change practice as a result of this trial, what would be the practical steps that we need to take so that we can create a sort of toolkit to say, okay, great, these are the trial results, and here's a toolkit to support its implementation into practice. So that's understanding the barriers, understanding the solutions. Going back to the very first point, needs to be context specific. Not everywhere's going to have the same barriers, not everywhere's going to have the same solutions. So kind of complex picture of different needs in different places. So yes, I think those would be my reflections. So kind of taking that holistic view of clinical carbon cost outcomes in clinical trials, making sure we're collecting the right information to do that, and then doing the preparatory work to be able to implement our findings rapidly so that we see that patient benefit rather than 10 years later and we're still not really implementing it.
That's excellent. I'd learned so much in this, Dmitri. I'm seeing that you go with your three C's are really clinical, cost, and carbon. So that is a fantastic thing. And thank you for making that connection and giving that example that it would have, when I looked at the cheetah trial, it was like, yes, we are actually using more gloves, but looking at that holistic view is extremely important. Praveen, let me ask you this, that when you said that reducing certain gases improves patient outcomes, connect those dots for me. How does using a different gas versus other changes the patient outcomes or any other benefit to the patient?
I think the big factor is these anesthetic gases. I mean, their impact, it doesn't really matter from a patient's point of view which anesthetic gas is being delivered. Yes, some gases have some unique properties. For example, the idea desflurane gas became very popular is because it has rapid wake-up times. That was one of the arguments that was made. This gas has a low blood gas solubility, so it will come off from the system very fast, so patients will wake up faster. There was a randomized control trial done that actually shown that the patient's time to wake up was literally like few minutes better as compared to other anesthetic gases, but there was no difference in terms of discharge of these patients from the recovery rooms. So the bigger question we need to ask is, by providing anesthetic care with a gas which is much harmful to the environment without giving us any extra benefits in terms of outcomes, is it really worth it? Why are we using it when we have other anesthetic gases, or in other words, using other strategies which will provide you the same benefits without compromising on quality of patient care? So that is basically the argument. We can easily provide safe, clinically better sound anesthetics by doing all these simple things. Remove the anesthetic gas which is not good for the environment, and decommissioning nitrous oxide. As I said, we are not saying that you should not use nitrous oxide. There is a value of using nitrous oxide in certain clinical conditions, but as I said, less than 10% is used on patient clinical care. So we are actually impacting the 90% problem and giving the physician still the flexibility to use these anesthetic gases by utilizing simple strategies like low fresh gas flows, utilizing intravenous anesthetics, and so on. So I think that is where the argument is, that it does not make better outcomes by using anesthetic gas like desflurane as compared to other anesthetic gases.
Thanks, Praveen. Dmitri, you mentioned that you can do the research, but the real world implementation can be really challenging. You mentioned that how Virginia has been doing, connecting with the teams and trying to assess that what are the challenges and understand their perspectives. Is there any particular strategy at your health system or any other institutions that you have interacted with that has worked very well or not worked at all?
I think it's fair to say that what really doesn't work is lecturing people. I think you need to have a positive engagement, and I think in general terms, when we're trying to influence people, it's about understanding what are their priorities and their drivers. So this is a big thing in public health. There's lots of things we think would benefit public health, but we have to tailor the messaging to the audience. So, for example, last year we had a change of government in the UK, and therefore, if you work in the Ministry of Health, the arguments you might make in support of a particular intervention would change. If you were speaking to a Conservative government, you would make a case about a particular intervention that reduces, let's say, smoking, that this will benefit the country by reducing workplace sickness rates, increase productivity, reduce welfare bill. And now with a sort of more left-wing Labour government, you might talk about the impact of smoking on health inequalities. And this is one of the reasons why, in our city in Birmingham, for example, there's a 10-year difference in life expectancy between the richest and the poorest. Lots of reasons for that, but one of the major kind of mediators is the fact that there's huge inequalities in who smokes. So a similar concept is that when we're trying to implement things in the hospital, we need to kind of understand who are our stakeholders, what are their priorities and their drivers, their values, and then tailor the messaging to that, rather than just sort of doing that kind of virtue signaling thing that makes us feel better about ourselves, but perhaps is at best ineffective or at worst actually alienates the audience. So that would be my very pragmatic approach to mobilizing change on the ground.
Well, so true, Dmitri. I think if you don't do it right, you do land up alienating people, and it's hard to bring them back to the table to listen to you. So, like any procedure, any medical decision, or any engagement that you do, you have to do it right the first time. Otherwise, it's much, much more harder.
Yeah, and sorry, just and I think that's where the thing about the cost and the clinical outcomes is important, because actually for some people they don't necessarily think the climate change is a big issue. They don't necessarily think it's the hospital's responsibility to tackle that. And therefore you would center your arguments not on the carbon aspect, but on the fact that actually this will save money for the health system. This will make sure that our patients have the best possible outcomes, and who wouldn't agree with improving patient outcomes. So I think it's identifying those parallel benefits of what you're trying to achieve. I think that can be very powerful.
Sounds good, Dmitri. If you have to pick, one or two articles or one or two type of research that you would love to see in this space, what would it be?
So if I was yourself and I was editor of a journal, what would I commission? I think there's a big discussion to be had around what the trade-off is between carbon and cost and clinical outcomes. So again, clearly there are big differences between the US and the UK health systems. In the UK or in England, we have an approach to considering the cost effectiveness of interventions where we will pay up to a set amount of money per quality adjusted life year. And at some point we say, actually, this is going to be too expensive. The health system is not going to pay a huge amount of money for minimal patient benefit. And so my question is, should we be doing the same with carbon? Is there a point at which the amount of carbon intensity of a particular treatment starts to outweigh the individual patient benefit? I think that's actually a much more difficult argument to make than around financing, but I think that's a question. And then what is also the trade-off between cost and carbon as well? So let's just say that a particular two interventions are similar in terms of their clinical outcomes, but one costs more but has a lower carbon footprint. Is that something we're willing to do? Are we willing to pay to reduce our carbon footprint in that way? There's not going to be a universal answer. It will be context dependent on your health system, how it's funded. But I think there's an interesting ethical debate to have. So I think that's definitely something that you could consider. I think another thought is to consider bringing together a bit of an umbrella review, looking at what we've already been discussing, the barriers, the facilitators, the implementation, and having a more of a generic kind of toolkit for how we approach this. Because one of the challenges we have with implementation research is, yes, it's great to do that research for each particular intervention, but it is time consuming and expensive. And so can we have a more generalized kind of approach that might inform what people do? Those are my thoughts.
Those are fantastic ideas, actually. I was also fascinated when you were mentioning the carbon model. And having this cost and carbon weigh against each other and balance each other out is actually a phenomenal thing. Praveen, I know that you have done some work and thought about this. Any comments on that?
So yes, I will actually add two comments to complement what Dmitri said. First of all, for example, robotic surgeries generate 30% more waste as compared to other approaches to surgeries.
I did not know that.
So so to answer that, it is benefiting one patient, but it is coming at a higher cost. That is environmental cost. Teaching hospitals generate far more waste as compared to non-teaching hospital, primarily because of increased duration of surgeries, teaching nature of the hospitals. So we really have what we really need is some sort of a risk stratification by collaborating with infection prevention services and deciding which practices we really need to revisit, because a lot of these things are done because of infection prevention constraints we have in trying to bring changes in our system. For example, because of the Inflation Reduction Act, we have not invested in promoting reprocessable industries. Our business model of selling most of our devices is for single use. So it's a conflicted business model. All the industry want to sell us more of these single use devices because that's how they generate more money, more revenue for themselves. So they really have no incentive in making these services more sustainable. And as you already know, that 70% of our scope emissions in healthcare comes from scope 3 emissions, which is a supply chain. And that is the biggest elephant in the room. And I think we need some sort of a government intervention to create policies so that way we promote reusables, reprocessables, to not only address waste generation, but to have a much bigger impact in making the health services more greener.
Thank you, Praveen. I know that we have a few audience questions that we will take in the last 15 minutes, but I want to ask you one last question that you've both have spent a lot of time and energy in educating people about sustainability, and you have created teams that can actually take this work forward. Dmitri, you have a lot of trainees, postdocs, etc. in your team. How do you educate people about sustainability? How do you think this work will go forward beyond our lifetimes?
I think one of the key areas is around identifying champions. So people who are passionate, who have taken the time to educate themselves, who can influence their peers and sort of bring them with them and educate them. Because it's not necessarily the case that a surgeon coming to give a lecture to a group of anaesthetists or vice versa, or a doctor lecturing theatre staff is necessarily going to be very productive. Actually, having key people within those peer groups who can talk to their peers, who's trusted, who's known, is probably more effective. So I think that would be my thought, is developing those networks of champions, which is what sort of our surgical associations and colleges have done at a national level.
Well, I like, Dmitri, what you said. Sometimes the people with the most knowledge are the people who have no voice, but you need to find the champions who actually know what is happening, how the workflow is occurring. Praveen, last few minutes about your green curriculum. It is fascinating. I had the privilege of learning from that curriculum myself. Why did you create it, and how has the adoption been?
I always believed education is the only pathway to bring change. And I think that was my first and foremost incentive to make this change. I learned whatever I learned over the years, I said I have to share with everyone. So we created a green team first after that, and which was a multidisciplinary arrangement or collaboration between our nursing staff as well as our surgical colleagues. And the primary focus was to address waste generation in the OR. This green curriculum came into practices because I believe habits are really hard to change. But if you can inculcate these good habits during early part of your training, then it will go a long way in teaching the next generation of our anesthesiologists. So we have created an elective green rotation. It is a 2-week rotation where residents get a chance to work with faculty who is passionate about bringing sustainable practices in the healthcare. They go through this curriculum, they learn about it, and we also encourage them to take anything quality improvement projects related to sustainability. The idea is for us to tell them what does it take to bring change. Change does not only happen with education, it requires bringing all the stakeholders into the table and trying to convince why this matters. So I think the idea is to help them learn the whole process. And yes, there are sometimes failures. Sometimes things don't work the way they want to do it in terms of bringing changes, but at least they now have the knowledge and education. And after they graduate, wherever they go and practice, hopefully these practices will stay with them and they can create their own green teams, their own green, I would say greening the OR modules to bring changes.
Well, thank you, Praveen. And I hope that green curriculum is publicly available at some point in time. So you've done great work there. Okay, so ready to move on to audience questions. There's a few very great questions. Praveen, I think you probably just answered this question, but maybe take this one. How can we build sustainability into the core competences of future perioperative leaders?
I think, as I said earlier, you will have to make a case both in terms of, first of all, collect the data. If you have a way to know what is your carbon footprint coming from anesthetic gases, coming from surgical care, it will be really fine. Find a surgical colleague who can co-champion with you, so that way you are not only addressing the anesthetic aspect of carbon emissions coming from surgery, but also from the surgical waste. Just to give you an example, 75% of the waste generated in the OR comes from surgery, and around 25% of the waste generated in the OR comes from anesthetic practices. Anesthetic gases, of course, are greenhouse gases. That's a separate issue. So if you make a case collaborating together, and I would say start small. You cannot do 10 projects at the same time. Pick up 1 or 2 projects, get the results, bring small changes, convince the audience. I think that will give you the momentum to take even additional projects. These things takes time. Changing as the culture does take time, but if you are persistent on doing all these things, I think I'm pretty sure you will be able to accomplish those. I think that's the best way I can address it.
Oh, thanks, Praveen. And I think it is important that small changes can make a very big impact. So I think starting small doesn't mean that the impact will be small, but you have to start with 1 thing or 2 things at most.
I would say start small, but think big.
Oh, I love that. Dmitri, so I'll give this next question to you. How can hospitals accurately measure and report the carbon footprint of surgical care? Are there standardized tools or frameworks available?
That's a really good question. And I think it's almost a philosophical question in that our data for understanding the carbon footprint of procedures is relatively limited. If you go and you look on PubMed, you will find probably, I don't know, a couple of hundred studies where people have carbon footprinted different procedures. But the approach to that carbon footprinting isn't always very consistent, which means that the data isn't always very easy to interpret. You might find very different results for the same procedure. And part of that is how people have measured stuff. Part of that is that it is just different in different places, depending on the supply chains, depending on, preferences and practices. So, and there is still a huge gap for many procedures for which there's very little evidence about carbon footprints. So I think, and then of course there's the fact that, it depends if you're in a country where you have entirely coal powered electricity supply. It's going to be very different if you're in a country like Scotland, where they have very, very low carbon footprint to their electricity supplies. It's mostly renewables. So that will make a huge difference to what your carbon footprint is. So the answer is that you can use very generic tools online. You can find where they will give you an estimate for what the carbon footprint is for a particular hospital, taking some factors into account. But there isn't really a good way of estimating carbon footprints at a at a more granular level, I would say. And the confidence intervals are probably quite huge around those estimates. So yeah, it's a bit of a challenging area. The philosophical question is to what extent that's worth doing. Now, of course, there's an element that people will take notice of things that you measure, and that has an impact. But if the amount of time and effort involved in measuring something is actually taking up more time than actually, doing the change, then I think there's a question of how valuable that is. So just to finish on a kind of concrete example, with Virginia's carbon model, what we actually found was that in the end, you could measure the carbon footprint of all the swabs and the antibiotics and the dressings and things, but actually, by far the biggest contributor to the overall carbon footprint of these patients was the length of stay and reoperation. And so there's an argument that actually, there are surrogates like the number of operations we do and the total bed stays that are probably better surrogates than, or more pragmatic surrogates than trying to estimate, the carbon footprint of every bit of plastic. Because to do these life cycle analyses takes many months, and it just is beyond the scope of what most people can do.
That is interesting, Dmitri. So it seems like surrogates worked almost as good, and the time and effort in calculating this can be really intense. Praveen, anything to add from your work? Because you went around you were probably one of the first few people to talk about this at your institution, and there was no way to measure, there was no way to do anything. Was there some magic framework that you created that worked for you?
I think, as I said, once you show results, I think everyone wants to do the right thing. And when you make a case, I think folks looked at, these are some of the things that have these are very low hanging fruits you can really do in your institution, but you have to make a case. You have to convey the message, so convincing becomes easier. As I said, all these projects, reusables, anesthetic gases, we started recycling program. It never started on day one. It took us a while to reach there, and we did it systematically. We made the same approach. We are going to make it as a business case. We are going to make it as an environmental case, and we are going to prove it does not compromise on quality of care. So all those three tenets really made our case stronger, and then convincing was easy, and that's the easiest way I can say that.
Thanks, Praveen. I think you partly answered this next question, and look forward to any additional comments. So the question is, while the need for sustainable perioperative care is clear, implementation often runs into institutional and systemic barriers. So can you share strategies on how healthcare teams can navigate this resistance or inertia within institutions to implement carbon reduction initiatives?
So I will say this way, that in order for any idea or intervention to be sustainable, as I said, it also has to be profitable for the institution, because if it is not profitable for the institution, then it is considered as a subsidies. And subsidies by definitions are considered temporary, especially with change of leadership priorities. We see it at the federal level, so the government priorities change, or if economies collapse, then these subsidies may disappear. But if the idea or the intervention is also profitable for the institution, it creates a value in excess of the cost. It then finds acceptance, and it also becomes a good business model. And I think I will put the tenets of good business models simply saying a good business model has to be socially desirable, emotionally relatable, technologically doable, financially viable, and above all, environmentally beneficial. So if we fulfill these 5 tenets, we accomplish the goals. Now, to answer your questions, I think, as I said again and again, I think the answer lies in starting small, making a change, and then create with an educational grant rounds. If there is no one in your department has given a grant rounds, give a educational grant rounds to all the audience and try to make a case why this is important. Pick 1 or 2 projects which you think are doable in your practices, start with them, show the results, and then start building up on it. There's extensive amount of educational material available, folks who are doing that, and we are happy to share what we have learned over the years to help you grow in your own areas of influence.
Thanks, Praveen. I think one thing that I felt was important when these grand rounds or educational talks happen is that we all go around our business taking care of patients, but we don't stop to think how much waste is actually happening around us until somebody stops you and tells you that, because we're just so focused on our day-to-day clinical care. Dmitri, you also mentioned some similar challenges that taking research to real-world implementation is challenging. Is there any tips for the question that was asked by one of the audience, that any polls of wisdom that you have?
Yeah, I mean, I think we've sort of talked about it already, which is that I think the key with implementation is to start thinking about that when you start your research. It's rather than something to kind of suddenly panic about at the very end, start thinking about learning from the process of doing the research. So setting up the intervention as part of a research study, and thinking about, okay, well, how will we scale this up efficiently and effectively when the time comes. So planning ahead is as always key.
I think this is not just research for the heck of doing research, but you are also thinking how to make change in the real world. So just like you want to think about the study design, want to think about the steps ahead of time, you also want to see how it's going to be practically useful and implemented ahead of time. We have one last question in the last couple minutes. How can stakeholder consultations inform and support the development of effective strategies for reducing carbon emissions throughout the medical life cycle, from supply chain and operations to patient care and waste management? I think we've touched upon this in various ways, but any final comments that you would like to give?
I think scope 3 emissions are definitely the hardest things to change because it requires collaboration from industry and other stakeholders. I think department leadership can collaborate with them, and a consortium of different hospitals, if they collaborate with the industry and other leaders, I think we have a stronger voice, we have a bigger voice, and that may allow us to bring some changes in our system. For example, if as a group of hospitals we go to some of these industry leaders and say, this is what we really need to address or bring reprocessables in our practices, I think the business case will be the driving force. So as a united voice, we have a stronger voice, and that brings change. Otherwise, at least in the US setup, where there are no incentives for the industry to bring these changes, it becomes extremely challenging.
Awesome. Dmitri, any final comments before we close the webinar?
Yeah, I think in terms of stakeholder management, as we've said, it's about making sure that everyone is included, not just the hospital managers or the senior surgeons and anesthetists, but the whole team, because you're going to be relying on those team members to implement whatever change you want. And often they will have really good insights and really good ideas about what will and won't work, much better than management do, who aren't involved in the day-to-day. And of course, working with patients to understand their perspectives on what's important to them, what won't be acceptable to them. So that's sort of key. So those are the key points. I mean, I think Praveen mentioned about scope 3 emissions. There's also some challenges that some of this is outside of the direct control of any individual, in the sense that there is, at least in the UK, there are quite stringent regulations around how things should be packaged, for traceability, for infection prevention control reasons. And maybe some of that is appropriate, maybe some of it could be changed and improved. So I think it's that would be a question working with industry, with government, with hospital providers, to find solutions that work for everyone, but not something that you can do in a silo by any means.
Absolutely. Well, thank you so much. I learned a lot from both of you. So thank you for sharing your expertise and your time, and really appreciate it. And I hope this was valuable to our audience. Thank you to all the audience for joining as well. Jenny, any last comments from you?
Yeah, thank you so much, everyone. I just wanted to thank today's panel for, providing such valuable insights on getting to net zero in surgical care and taking the time to share your unique perspectives with this audience. It was great learning about how prioritizing sustainability in surgery can, really be a win-win-win scenario for everyone, the patients, the institutions, and the environment. And I also really liked what you said, Praveen, about starting small but thinking big. So I think everyone today will walk away with some great takeaways from this session. And with that, I just want to remind everybody that, as I mentioned earlier, this session was recorded and it will be made available later in the week. So look out in your inboxes for a link to review the content later or share with your colleagues. And again, just thanks everyone for attending. Thanks again to our wonderful speakers, and we hope to see you at another webinar in the future.
Thank you very much.
Thank you so much, and thank you, Nidhi, for the invitation to speak, and it has been phenomenal. Thank you all.
Thank you.